Okay, well, welcome, folks. I'm Diana Hill, and here with Joseph Ciarrochi.
Oh,
And today we're talking on how process-based therapy is revolutionizing treatment, moving beyond rigid diagnoses to powerful, personalized transformation. We have some fun things planned for you all. But first, we just want to offer you a chance to get some bonus material. There's a link here, pages.drdianahill.com/ppt. And you'll be getting the slides for this in your inbox through PESI, but you can also get the slides to this talk today. We have some frequently asked questions that Joseph and Stephen Hayes worked on about PBT that I was just reading through before this talk, and it was like, oh yeah, it's so good. They're answering all the questions that you may have that maybe we may not answer today. There's going to be a link to the digital networking tool that we're using, as well as something that Joe has created that includes tons of research articles and resources and books. You keep on updating it, right, Joe?
yes, indeed.
Yeah, so folks can get that at this link.
Oh, okay, I'm up. So Diana, I thought we would talk a little bit about why we got into PBT. I am very much interested in helping people to thrive and lead full, fulfilling lives. So I have a very positive focus, I suppose, rather than a curing disorder focus. But the big thing about process-based therapy for me that is exciting is that I have an interest. I'm an ACT practitioner, acceptance and commitment therapy practitioner, but I'm also very interested in psychodynamic therapy. I'm interested in schema therapy. I'm interested in self-determination theory. And I never really had a way to kind of cross those different therapeutic islands and bring it together into my own practice. And I think PBT is a way of doing that. It's a common language, so it doesn't ask you to change your therapy, but it gives you a kind of way of thinking about therapy that allows you to be, for me, an ACT practitioner, but also use stuff from psychodynamic or from attachment theory. So it allows, I think it allows me to be an ACT practitioner, but to be more creative and expansive in what I do. So that's where I got into it.
And I'm Diana. I am also an ACT practitioner, but I'm a lot of things beyond an ACT practitioner. And like Joe, there's a lot of different modalities that I pull from. And I imagine that's the case for you, that you don't follow some protocol like maybe you learned it in graduate school, but rather you bring more of yourself into the therapy room. And PBT offers that. So I'm very interested in biological, nutritional, the impact of movement on our mental health, things like that are sort of outside of the therapy room, but we know are really influential on mental health. So I love that PBT is a biopsychosocial model that incorporates all the aspects of the human being, and even could include spiritual as part of that. So I'm excited to take a deeper dive. And the other thing is I just want to be at the cutting edge of psychology. I've always been that case. I'm always kind of like want to know what people are doing that's advancing the field of psychology. And I would say PBT is very much there. So I'm glad you're here with us. So to give you a quick walk through what we're going to do today, we want to answer the question, what is process-based therapy, and why, we're using this way of conceptualizing cases, and the problem with the DSM, as well as the big question, what is a process? That's the question I kept on asking Joe. What is a process? And even when they give us the definition, I still ask that question of what is a process. So we're hoping that you can actually feel it, try it on through an example of a process-based case conceptualization. We're going to be doing a real play, and Joe's going to be the client. So this will be fun, as well as answering frequently asked questions along the way.
And I've included a link with a lot of the research that's happening behind the scenes. There was a recent meta-analysis showing that personalization of therapy improves outcomes over, say, manualization. So that's really a core feature of process-based therapy. Again, process-based therapy is you being a therapist, but in a way that kind of hopefully unlocks a lot of your skills and talents and lets you expand. So any limitations and treatment risks, for example, for me, are whatever is true for ACT is also true for PBT. So it's your normal kind of knowledge as a practitioner of the limitations and treatment risks of what you do. So it's not really a new therapy, but it's an expansion of what you do in a certain way. So there's a lot of words here. Don't panic. We put a lot of words into a few slides because you guys are going to have these as review notes, but we're going to actually walk through this, and I think it will become obvious what each of these things mean. So network-based, we're going to do a network, individualized, biopsychosocial, evidence-based, and flexible.
So I work a lot with body image concerns, eating disorders, and this was a model that I started talking with folks about when they would say, "Why do I hate my body so much?" Right? And in an evidence-based package, we may just sort of throw one approach, like see just sort of one factor. Well, maybe it's because you grew up in a household where somebody modeled negative body image to you, or maybe we just focus on culture, or maybe we just focus on the individual's psychology. But with process-based therapy, we're able to unpack the many different things that are influencing somebody's problem. And some of those things may be physiological. So today we're going to do a intervention with Joe where we're going to look at like, wow, is there something like physical tension due to stress that's contributing to your problem? Or maybe it's somebody's diet, or maybe it's somebody's sleep. Do you notice that your body image is worse when you're really hungry or when you don't get enough sleep, right? And then there's the psychological, which is the things that we are already targeting in therapy. Things like someone's thought difficulty with their thoughts, or somebody's difficulty regulating their emotions or tolerating their emotions. Maybe somebody's difficulties with motivation or their sense of self. And then there's the social components of people's problems. We know that, sometimes people's problems have to do with difficulty asserting themselves in their relationships or creating secure attachment patterns. And then finally, these environmental contextual elements, and how can we help our clients re-engineer their environment? So, for an example of somebody with body image concerns, we may say, hey, maybe don't follow that person on your feed that always is showing dieting tips, right? So the PBT Russian doll is our ability to break apart and look at all these interacting factors and see which ones are the most influential in people's lives so that we can actually target them and be precise in our targeting. And it really follows this biopsychosocial model where there's the physiological components that are impacting our clients, there's the psychological components, there's the social components, and there's the environmental components, the contextual components. All of these are playing a role in your client's life. And you already know this, but we're going to be offering a way to actually map it out and look at it and have a clear sense of, okay, what's doing what? Where do I intervene first? And we'll be showing you some of the many different processes that exist within physiology, within psychological components, within social components, and within environment.
And it all starts with how we think about people, how we think about our clients. And the dominant approach in academic training is the DSM-5. And so what we're going to offer after this slide in the remainder of the workshop is an alternative way of thinking about people. So it's really foundational, this. So DSM has a lot of problems. I just read an article saying that 69% of the people on the working group for the DSM-5 have a conflict of interest in that they're associated with big pharmaceutical companies. So that's shocking. And when you start to think of normal suffering in terms of disorder, medical disorder, it really changes how you think about people. So let's take a look at how the DSM does this and its limitations. So one problem is that the DSM isn't massively useful in a lot of ways, because if you diagnose somebody with generalized anxiety, well, we know that people can have general anxiety in very different ways. They can be going through a divorce, or have a really threatening neighbor, or they can have a health scare, or, there's like 1,000 different ways that you would be anxious. So it doesn't really tell you much. So because it doesn't tell you much, it doesn't really directly tell you what kind of intervention you might do. It'll depend a lot on the details of why a person is depressed, for example. The DSM 5 is also categorical in that you have the disorder or you don't. And I think that has to do with the medicalization. They're trying to say, well, if you have the disorder, then you can get this pill. And they don't recognize that actually, my life has lots of pain and suffering. And it's not because I have a disorder, it's because I'm a human being. And it's normal to struggle, for humans to struggle, and sometimes become sad or very anxious. So it turns normal human experience into pathology and disorder. And that makes it easier to sell pills, of course. And the medicalization is where we really get to, it suggests the way that it's approached like a physical disorder is it suggests that we need medical treatment for this. But there's really been, they've had decades and millions of dollars trying to map the genes to depression, trying to prove the chemical imbalance theory that you're depressed because this serotonin is out of sync with whatever. And there just really is pathetic evidence for this. And the medicalization also tends to take the focus away from context and the way that a person if you're in a toxic workplace, a really bad neighborhood, you have an abusive partner, like it's not because you have the wrong genes, it's a lot to do with your context, and there's ways that we can actually help. And I think the DSM-5 also has an overemphasis on symptom reduction. Like if you have a disease, you need to get rid of it, right? But if suffering is a normal part of life, of doing things that are important, of stepping out and taking risks, and that comes with anxiety, then it doesn't make sense to try and eliminate or reduce it. So I think it overemphasizes symptom reduction.
And if you think about a client that you have right now, that maybe you think about a client that you've been working with for a while, that you could certainly say they fit a certain DSM diagnosis because they have 5 of 9 symptoms. But if you think about who you've been working with, how probably you've been working with them in a lot of different areas and domains of their life that are related to the reason why they're coming in for therapy. So the DSM doesn't really give us guidance in that of where to intervene and how. And you're already probably doing some of this. I think that's the message we also want to say is that you already are doing a lot of process-based approaches. You're doing it through your clinical skill. And we're going to offer you, some ways to do it that have a little bit of a structure, but not a procedure.
Yeah, that's interesting. I think a lot of people do it intuitively. And the challenge with that is that sometimes you may be a really brilliant therapist, but if you can't make the principles more explicit, it's very hard to teach it, to transfer it. And so I think that's one advantage of having a more systematic kind of framework. And so here's a really complicated definition. And we put this in there. You're going to get these notes. Every term in this is important. And we're going to kind of walk you through in an experiential way to introduce what they mean. But I would say keep this slide in mind. So as you learn about process-based therapy, you want to know what we mean by theory-based, meaning I'm an ACT practitioner, so I have a very clear theory about suffering. Dynamic, meaning it's about change and people are changing, then important processes are changing. Progressive, that just means like you target some process before other processes. Contextually bound just means, self-compassion, you don't just give that to everybody because you think it's an inherently good ingredient. It may be useful for some and not useful for others. Multi-level and modifiable, we'll see about that. We're talking about body, psychology, social, culture, every different level. And towards desirable outcomes, which are often things you work with your client. So we're going to unpack that during the rest of the workshop.
Thank you, Joe. That was such a good description. I read that this is a paragraph that's inserted into papers. And every time I get to it, I sort of have this internal resistance to even reading all these words. So I appreciate you. Just that little definition of each one. That was helpful. Okay, good. Okay, so you may be asking, if you're saying that the DSM has all these problems with it, what in your practice, you may get reimbursed for the DSM diagnosis, you may have to work with insurance companies. Do we still provide a DSM diagnosis? And then if we don't, what do we do?
Yeah, and I think you have to be practical. I think the DSM may have its uses, and maybe what we're going to show you today would just be a complement. Or if you have the freedom, you may decide that you want to just have outcome measures that aren't always, following the DSM, but it's going to be dependent on your context and it still may be useful to do the DSM diagnosis. What we're going to show you today doesn't conflict with that.
Yeah, I listened to a interview of a nutritionist at Stanford who studies diets and what's the best diet. And he said he was writing a book and he wanted to title the book, "It Depends." But they couldn't let him have that title, right? What's the best diet? Should we provide the DSM diagnosis? Well, it depends. And a lot of process-based therapy, I think, allows us to sit in "it depends" as the answer, so that you can really customize it to you and your practice and what works best for you and your clients, and what your outcomes are and what you need to do.
Okay. I mean, in
But
Australia, you have to have it to be reimbursed by Medicare.
yeah,
I'm pretty sure. Yeah.
but we do use something else in terms of our diagnosis, and we're going to be demonstrating that to you, which is something called a network-based diagnosis. And Joe and I are going to show that to you live. Before we do that, the other related question is PBT an alternative to other therapies? Another acronym.
Yeah, it is not. It could be called, it may be better phrased as a process-based approach. So it's a way of thinking. I think it's a way of thinking that it may not be obvious, but as you get deeper and deeper into it, it really radically changes, I think, how you think about people. But it is like, I'm still an ACT practitioner and I'm a process-based practitioner. A psychodynamic person may be the same. So hopefully, as we demonstrate this, you'll see, oh, I see how I could still be follow the theories and principles of my practice, but kind of be more creative by using this process-based approach and expand what I do and try new things without being inconsistent with my theories and what I have done before.
Yeah, once you start taking this process-based view on things, you start seeing processes everywhere and across different theoretical approaches. I interview people from all different backgrounds. So people like Richard Swartz of internal family systems, and Stephen Porges from polyvagal theory. And when I look at them and what they're saying through a process-based lens, I can understand, oh, family systems, he's targeting these processes with this type of intervention. Oh, polyvagal theory, they're targeting these processes with this intervention. And so it's a way to be able to look at all these different, like, it's almost like people are speaking many different languages, but many of the psychotherapy interventions are targeting the same things. They're targeting your affect, they're targeting your motivation, they're targeting your thinking, or maybe your biophysiology. So it's not an alternative, which is a relief. And it is unfortunate we have to learn another acronym.
I mean, I think different psychotherapies have different strengths, just like different types of martial arts have different strengths, so it's, it allows you to kind of recognize the value in the different approaches, but then also at least talk to each other and see if you can get value from the other person.
Okay, well, Joe, let's do a real play. A real play is something that we do in ACT, which is where we bring in a real issue that you have in your life. We don't do role plays, we do real plays because it's a little more juicy. And one of the ways that we start, a process-based therapy session is, tell me about a problem that you're having, describe it to me, and then we'll work together using this networking tool to network it and do some interventions. So Joe, tell me about a problem that you're having.
Yep. And just to flag to people, Diana and I are probably going to go a little faster than we normally would. This would be like therapy on steroids, or yeah. So we're going to be, we're not modeling the pacing and all that Diana would normally do. But my struggle has been with being a permissive parent when it comes to internet with my adolescent boy. He's a 14-year-old boy named Vincent, and he can be quite addicted to the internet and disappear into his room with his phone and not interact at all with the family. And I feel like I'm very hesitant to control it, largely because I get very distressed. I'm afraid of being estranged from him, because I had this really difficult relationship with my father, and I was very much distant from him. So I'm kind of like, my entire life is now, don't be like your father. Do not do that. Have a relationship with your son. And so I feel a lot of distress at the idea of restricting that, because if I go to restrict and take the phone, there's going to be a major battle. It's going to be a fight. And yeah.
So I guess just first I want to say I relate to your challenge with kids and technology, but also just the challenge of being a parent, and how hard it is to set limits, and also the influences of our parents on our parenting that show up. And there's this distress that's there. That's like, it sounds like it kind of pushes you around a little bit when that distress shows up. You end up becoming more permissive with him, which is not what you want. You want to be able to
so
set a
much
limit.
easier just to say, I'll let him have it. He's up in his room. He's being quiet. I'm busy. I've got a huge day. I've got a lot of stuff going on. And
Yeah.
so I know it's probably not the right thing to do, but
Yeah.
I
It'd be a
do
lot
it.
more, it'd be more uncomfortable to do the thing that you want to do. I'm wondering, Joe, so you mentioned this relationship with your father that plays a role. And I'm also wondering if there's times when it gets worse, like there's times when it's more difficult for you to set limits with him around the technology, and what's happening during those times.
Yeah, definitely. Like if I have a huge amount on during the day, like, and I just have to, like, there's emails waiting, there's jobs waiting, I have deadlines. I just am such a rush, and I just feel so stressed. Like it's like there's a sniper in the trees pointing a gun at me, and I'm just like running as fast as I can to survive. Then that's a time when I just don't want to take on that battle.
Mm. Yeah, like your resources are really low because you're under such threat and stress and demands that there's like nothing left to be able to go and face the distress of doing the right thing that you want to do with your son. Yeah.
Exactly.
Yeah. Okay. So there's a number of things that, as an aside, as your therapist, that I would be thinking about, as you share this problem. The first thing I'm thinking about is, what is it that he's wanting? What does he want to be different in his life? And then what are the different components that are sort of playing a role in this problem? And I'm hearing a component of distress, of the fear of, making his son upset. I'm hearing the component of his father, the role of that relationship. And then I'm also hearing the component of the busyness and the physical stress that's going on.
There's also the kind of disappointing thing is when I don't draw the boundary and he's in his room, there's this like real big disconnect with the family. He's like separated. He doesn't come down for dinner, so ironically, I'm feeling he's even more distant when we don't draw the boundaries.
Yeah, that disconnection, is that related to your dad at all? That feeling of disconnected? Like,
It does cause me fear. Yeah. I mean, I spent my childhood saying, I wish my dad would spend more time with me. And
oh,
sometimes it feels like my kids are like, I wish my dad would spend less time with me, but that it's a different generation. And yeah, but definitely if he gets into that addictive pattern, then anything that opposes is a nuisance and it's a frustration and he doesn't want it. So that could even be just socializing with his family. So I think I need to have boundaries there.
mm-hmm. But it also sounds like you want to have boundaries in a way that are connecting to him. Like
Yeah,
that's part of it, is that you want a connection with your son and you're afraid of missing out
exactly.
on that connection. And so
Yeah.
you don't act because you don't want to do what,
Yeah.
your dad did to you, but then it sounds like end up in that result that you don't want to have, which is end up having more disconnection.
Yeah,
Yeah.
actually, ironically, he's up in his room just like I was by himself doing whatever. Yeah,
Mm-hmm.
it's the same. Yeah.
Yeah. Well, Joe, let's see if we can network this out and see how these different pieces come into play, because you also just shared another piece, which is the disconnection with your son and that sort of social component that's playing a role in here. And Joe has this tool that he's going to share with us about how we would network out an example like this.
Yes. So can you see the perceived life analysis network? Yeah.
Mm-hmm. Yeah.
Okay. So look, folks, you guys are going to have access to this, and it's just a simple tool. I created an app. It's not going to be as slick as Microsoft Office, but I find it very useful to think about these things. And actually, thinking about this issue was really helpful. I redid it several times, deleted it. So it's just be playful. You could do this by hand if you wanted to. But I'm just going to walk you through a step-by-step process of how you can do it with this particular tool. And I would say the first thing you do is just identify all the elements that we were talking about. So I'll just put those in to save time. I would start with what I think is the problem, permissive parenting. Can you guys see that? Is it big enough to see?
Yeah. Mm-hmm.
Okay. And then I would put in, so I'm just I'm putting in all the elements that were there.
And these would be considered processes.
Yeah.
somewhat, some of them. Yeah.
So you can see, so it's nice because it kind of, doing this process is a kind of way of stepping back and looking at your life in a bigger way. Just the key is just to not lose the heart part, not turn it into an intellectual or very cognitive task. So that's why Diana, and really just emphasize this happens in the course of a normal therapeutic kind of encounter.
And this may be something that you're doing on your own as a therapist after you have a first session with a client. It may be something that you sit down with a client and do with them right there. I think I have found they actually like to look at their network or work on their network because it also gives them sort of a vision, like, where do you think we should intervene first here based on this network? So go ahead, Joe.
You might start with the problem and put that in the middle. If you're drawing it, you might just draw that in the middle of the page and then gradually add things. But so in this approach, we first put down the elements. So let's just go with 5. Don't put too many because it'll get hard. As you get better, you might be able to. Then the next thing is to create the links. So for me, let's just say we're focusing, the problem is permissive parenting. And I find the big thing I was saying was distress. Fear of disconnection was the big thing driving permissive parenting. So I'm going to make that a 10. I feel like that really is driving it. So this may seem familiar to a lot of you guys. This is like functional assessment, right? This is normal kind of therapeutic stuff. Sometimes it's chain analysis. It has different elements. It's very much related to all that. So it's not completely new to you. Now add the edge. All right. So we have fear of disconnection going to permissive parenting. And then, but I also talked about bodily distress. And that was really driving some of my fears. Like on those days, my fear was even greater, so if I had a really stressful day, see if I click on that, then my fears were greater and I was even more permissive. And then we had don't be like dad. That's the big one. And for me, it's directly driving the fear of disconnection. Mm-hmm. And that's a big one. So I'll just put a 10 there and just play around with this, like there's no right or wrong way to do this. You can see when you click on a node in this, the things that are affected by that. If you were to, for example, target my father issues, this is what you'd be expecting to affect. So you wouldn't be affecting bodily stress or permissive parenting directly, but you'd be affecting fear of disconnection, which would then affect permissive parenting. So I hope you're starting to see how you might actually use this. And then the son family disconnection, this is actually a consequence of my permissive parenting. So go from permissive parenting to that, and that's a consequence. So we're starting to get a picture here, I think, of permissive parenting. Now, I would add just one more to keep this simple. Let's see. The irony, I was talking about this, a lot of therapeutic cycles have these strange loops where what you do is actually creating more of what you don't want. And so this is a good way to kind of imagine that. And so the son family disconnect, ironically, so let's say so that's actually happening from my permissive parenting, feeds into my fear of disconnection. I'll make that a 7. So just to show you, you can kind of arrange it, but you start to see a strange loop here, which I think is really important.
And Joe, I'm noticing, I'm noticing this at the kind of the center of here. We have one thing that has a lot of arrows pointing at it. Is that something that we should be extra aware of?
So if you were a therapist, if you were working with me, Diana, what would you see as the central process here?
Well, that fear of disconnection, because there's so many things that are kind of coming into it, and then it drives the permissive parenting, which is your primary issue. So if we could work on the fear of disconnection, that probably would be something I'd want to target.
So that's this one. That's the direct so that's just an intervention. So this is like a case conceptualization. But okay, so Diana, what if you I don't exactly, we've done an intervention where we've kind of helped improve fear, but might you target these as well?
Yeah. So I probably would target the don't be like dad and the bodily stress as well. But we could even target just the permissive parenting in terms of sort of as a social component of like what would be actually the more effective behavior that you'd want to do in place of the permissive parenting. And that would be from the social level of process-based therapy. Yeah. So the bodily stress. Yeah.
Oh, go ahead, Diana.
I
Sorry.
was just going to say, so each of these is sort of, we're going to talk about how they fall into those different rings, right, of the biopsychosocial model. And you'll get a better understanding of where they fit, because we have some handouts on that. But you're starting to think about, okay, you probably already would have some interventions for fear of disconnection, or you already have interventions for body stress, or you have interventions for when we have a belief that I'm afraid I'm going to end up like my dad. And you as a therapist have your unique ways of targeting those, but you'll be using those interventions and choosing which one of these places to target based on the network.
Okay, I'll stop sharing.
Okay. So I'm going to go back to our slides. And the first thing that, and this is the example of the network that we just created. And based on our network, we thought, okay, well, maybe the fear of disconnection is the thing to target. And when we're talking about a fear or a feeling state, we're talking about something called affect. And it's actually really, it's a psychological process, right? The fear of disconnection has to do with, what Joe is experiencing psychologically and what he's doing with that fear when it shows up. And psychological processes in process-based conceptualization, there's 6 different ones that we're looking at. We look at things like attention. Where is the individual, are they able to sustain their attention or shift their attention? Their motivation, their sense of self, their affect or their emotions, their thinking, and their observable behavior. So we're going to demonstrate how we would target this fear of disconnection. But is there anything else you want to say about the psychological processes, Joe?
That's really well put, Diana. We expand on each of these. So each of these you can think of have their kernel intervention. So mindfulness might be targeting attention. Motivational interviewing might target motivation. And Diana's going to kind of target a few of these things. Thinking, kind of classic cognitive interventions, diffusion, cognitive restructuring, observable behavior might, if that's suggested, you might do goal setting or things like that. Sense of self. So clearly there's a deeper issue here with my dad and myself and what I think of myself. So we're just going to focus on affect for now, but know that each of these kind of will link to a whole set of possible interventions.
And for those of you that are ACT practitioners, these will feel somewhat familiar because they do tend to fall within a lot of the ACT processes, right? So mindfulness, acceptance, diffusion, values, these fall under these different psychological processes. But there's many other interventions besides ACT that you could use here as well. Okay, so we'll go back into the real play, and I'm going to set, just to keep us on target, I'm going to set a timer for 3 minutes so that we can feel like we can just move freely and know that we'll be stopped in our real play. Okay, so Joe, we just mapped out your, that's the start meditating. We just mapped out your struggle, and it really seems like the fear of disconnection is the biggest, like one of the biggest parts for you. And I'm just wondering if you could describe that more to me, what that fear is like and what it is, so I can get a better sense of it.
I mean, just decided that I'd be a stranger to my son, that I wouldn't be part of his life. That's kind of terrifying to me. It reminds me of a time when I was, a young person, very completely and utterly alone. So, yeah, I maybe do over the top things to try and make sure that never happens again.
Yeah. What was it like when you were alone and a young person, and what was that experience like for you?
Just felt like, yeah, there was nobody there for me. It was, always imagined a better time in the future and would daydream, but the present was just me hiding out in my room.
Hmm.
And yeah, having no real connection with my father.
So that feeling is that's the feeling that gets evoked with your son, the feeling of having no connection, that fear of having that feeling.
Yeah, yeah, that's
If you,
one of,
yeah.
yeah.
So is there a recent incident when you had this happen with him?
It happens regularly. He's a teenager, so he wants to do his own thing. I took him to the movies the other day, and they were walking by themselves, him and his friend, and I kind of ran into him because I was going to see another movie, and they literally ran away from me because they didn't want to be associated with the father. I mean, at this age, kids like to pretend like they have no parents. But I'm accepting of that. It's okay. So those situations are okay. I have to let him go and
Hmm.
not
So there's
that
some
would be.
situations where you're accepting of it. You can let it go and you can see, okay, this is happening. But there's the other ones that maybe you're not so accepting of.
Yeah, I mean, I want him to be in the family, like at dinner. I want him to be present sometimes. I want him to be able to be present, to have that capacity to be present. I know he's got to do his own thing, but I just would like sometimes him to have that ability to take our perspective and be part of the family.
So if you were to move to like make a move to get him to be part of your family, what would you have to face to like go into his room and make that move? Like he's on his phone, you're
I'm
having
gonna have
dinner. What would you have to face?
I have to be unpopular. I have to go in and say, I'll need the phone now, don't, because I want us to be eating dinner together and having a conversation.
And
And
what's
it's
the,
time to go.
yeah. Okay. So I want you to imagine, you can keep your eyes open for this, but I want you to imagine that you were going into his room and you were going to have that conversation with him. Describe to me what it would feel like in your body if you were to have that right before you go in or
Sure.
as you're in there.
Yeah, like just a lot of distress in my chest, gearing up for the argument, telling myself not to get angry. But not wanting it, just wanting things to go smoothly, wanting to get on with something else,
Mhm.
not wanting to have this big battle every night.
So there's a not wanting it. I want things to go smoothly. I want to get on with something else, but I like, you don't want to stay in that state. If you were
No.
to describe, like, if you were to kind of stay there a little bit longer, tell me more what it's like physically for you. If I were to like feel what you were feeling, what does it feel like for you?
Yeah, it would be distress. I often just end it early so I don't really let it go to the point. You
Yeah.
know what I
So
mean?
let's let it go. Let's like stay in a little bit longer because here's the thing, Joe, in order to get what you want to get, which is more connection with your son, you're probably going to need to stay in that space a lot longer than you're
Yeah,
staying in it.
that's true.
It's easy for you when he runs by at the movies because you can just be like, oh, I can accept that he's moving on. But there's something really painful when it's part of your family,
Yeah.
and you're going to need to like show up as a dad. And this is part of showing up as a dad. And your dad didn't maybe show up for you in this way, but this is part of showing up as a dad, is being able to tolerate this distress. So just tell
Yeah.
me more like what you would need to feel.
Well, I need to have the distress, but not react at all with anger, just to keep my voice calm and patient, even if he's getting very upset or he's telling me, no, it's another 5 minutes. It's no, on Saturdays, I get to stay up this long and use my phone. Those, I need to kind of hear that all and just be very patient and non-reactive.
Yeah.
And then I have done that before sometimes, and he does calm down. If I stay very calm, he seems to calm down a bit.
My guess is it's staying calm, but it's also willing to be with the feeling that you're having. And the willingness to be with your feeling it's the willingness to enter into a relationship with your son.
Hmm. Yeah, that's true.
Because the relationship that he's offering now is a teenager relationship, which is a lot of
Yeah,
feelings.
yeah,
Yeah.
that's very complicated.
So if we were to, we got to wrap this up. But if we were to be able to, if you were able to leave and be willing to accept one, sort of one thing in order to stay a little bit longer, what would that look like for you?
It would look like me asking him getting very angry and elevated, and me kind of patiently explaining why I'm doing, like, I want you to be part of the family. This is part of it. You have to give up the phone now so you can come down and talk with us.
Uh-huh.
I'm not going to relent on this because I think this is really important. And just
Yeah.
staying really calm. It's actually, now that I think about it, I mean, yeah, it's distressing, but it'd be only like 20 seconds and it would be done. like literally 20 seconds of calm behavior would be all I need. I don't know why I think I have to do it so fast. It's that sniper. It's the sniper in the trees that I mentioned earlier. Everything has to be done quickly.
Yeah. So we'll do something to help you with that sniper self, that kind of energy around that's physically in your body. But what you're telling me right now is that in order to be the dad that you want to be, it's that you need to stay longer. And part of that staying longer is accepting the discomfort of it and continuing to communicate in the way that you want to communicate. And when we talked about your dad as playing a role in all of this, in some ways, it's like it's being the dad that you didn't have.
That's
and
true.
that will, in some ways, that kind of heals the relationship with your dad.
So. Yeah.
Okay.
Nice. That's
okay.
You've actually shown like other processes as well, kind of slipping in there.
Yeah. There was so many, we didn't practice this part of it. So there was so many processes that were showing up, and I was trying to stay on affect by getting you to practice acceptance, but you moved over to motivation a lot and talking about values. You moved over into thoughts. You moved over into, actually, you were starting to say, here's the observable behavior that I would want to do. So you were kind of moving all over these psychological processes. And for the demonstration purposes, I was trying to stay on affect, but it became clear that you have strong motivation and you actually have a strong sense of what the behavior is that you want to change. That it's that really it's the accepting the affect in order to get to that motivation and do that behavior.
Exactly. I think everything would really improve. Just 20 seconds now that I think about it.
So psychological processes that kind of follow these principles of evolution, which is also something that we do in process-based therapy, is trying to get you to do something different. Walk us through this, Joe.
Yeah. So the extended evolutionary meta model is the approach that we're using, and it's based in the principles of evolution. And the reason we've used evolution is because no matter what therapeutic position you come from, if you're in an evidence-based therapy, they accept the principles of evolution. So this gives us a common way of speaking to each other. And that's really important. So, for example, let's talk about what we were doing with affect. So these three principles are essential for any positive change, right? So no matter if you want people to become different, to evolve, to kind of develop skills and improve their life, they're coming into your therapy room. The first thing you're going to need them to do is do something different from what they're already doing. So with Diana, she was helping me to kind of do something different in relation to my affect, right? So instead of very impatiently either yelling or just giving up and leaving the room, so it's either extreme controlling behavior or extreme permissiveness, I was going to try sitting there and with my affect and staying calm and seeing what happens. So that's variation. So that's every process you're going to do. If you're going to help a client, you're going to get them to do something new. Now, selection is where I then go and I try that out in my life. And I say, well, did that work? That's the big question. Does it make things better? Does it improve my life? So selection is just, is this value consistent? Is it working? I might try that and it doesn't work, and I might have to try something else. And retention is very familiar to you. And that is like the things you do let's say, if it does work. Now, how do I make that more of a natural thing I do every single time? Like that could be like homework or practice. How do I make that skill a habit? So every single thing you do in therapy is going to have these three processes, I think, involved if you're trying to change people for the better.
And so what that may look like, I just brought up an example of when I had kids. I used to go to the gym, but all of a sudden I couldn't go to the gym anymore. So I had to figure out a new way of moving my body, right? So we're going to help our clients find new ways to get, basically get unstuck from their stuck places. And that requires variation. And then selecting the things that end up fitting your goals, right? So kids playing in the sand while I go to a dance class, or starting to teach yoga at my kids' school. These are all different ways you can move your body that builds that sort of variation selection and keep doing the things that are working. And in terms of the network, we would be doing that with fear of disconnection, starting with that one of like, we try out maybe for Joe, just the practice of, can you stay in it a little bit longer? Maybe we would set a goal of, can you stay in it for 5 minutes longer, working on acceptance strategies, and then remembering why you want to stay there and how you're being the dad that you want to be. If that doesn't work, we may try something else and select what does work. But the other components of this network that we're looking at are things like this bodily stress. And he even mentioned it. He said, you know, that's the sniper feeling that he gets. And that points to his threat system is being pretty activated. And you may have many different interventions that you use with bodily stress. But there's and we'll demonstrate one that Joe and I could use, but there's many different physical processes that could be impacting your client's problems. And these are often things that maybe your client doesn't bring into therapy, or they don't even acknowledge, or they don't. So this is where process-based assessment, you're going to be asking about all of these. And in our 6-hour, we'll talk more about, and we'll have a handout for you of how to ask questions around each of these physical processes. But they're things like, how much exercise are they getting? Is pain playing a role? Is their diet, nutrition playing a role? Their sleep, fatigue, medication or substances, health conditions? Anything you want to say on that, Joe?
No, I think that's really good. I think we do tend to have our favorite dimensions, and I probably underestimate this. And so I'm really keen to get to the really cool psychological, and we'll show you social later, processes. But sometimes if they're only sleeping 5 hours a day, or they're doing something really disruptive to their diet, like that's maybe the first thing you need to sort out. You know, if their diet is horrible and their energy's all over the place, like all the cool, fun psychological interventions may not work until you get that sorted.
And sometimes when we're working with something like an ACT model, and say we're working on acceptance, we may neglect something like the bodily stress because we're like, just accept it all. But there could be a really positive benefit for a client to be able to actually reduce the tension in their body, or be able to use something like soothing, rhythm breathing, which could feel like, okay, if I'm an ACT practitioner, can I do this? And in process-based case conceptualization, we say, yes, you can do that because it's targeting an important node. So going back to the network, bodily stress, and I'm just aware of the time, so we'll just spend maybe 2 minutes on this. And then I also want to answer a question that came up in the Q&A. But so for you, Joe, when this bodily stress comes up, one of the things that I was sort of thinking of is that you get so busy and you have so much on your plate. And one of the things that you've talked about to me is that you're really interested in martial arts. This is something we don't know about you.
Yeah.
And that movement can be a really useful tool for our bodily stress, as well as breath. We know this from a lot of ancient practices of like yoga with breath. We know this from newer polyvagal theory in terms of using breath to help activate our vagus nerve. And I was curious if there was something that you could do before you go in there that could help you with that calm that you were describing that you wanted to be, sort of the best version of you, so you can be a little bit more regulated. Is there any martial arts move?
Yeah, I guess. So now we're really in the realm of variation. We did not practice this, and Diana's surprising me, but I'm going to go with it. I don't know if this will work. So variation is like, the more crazy and outlandish you can be, the better, because we're just trying things out. It doesn't matter. But I guess there is a thing, I don't know if you can see it, where it's just where you just kind of very slowly and just focusing all the energy in your body. Like, let's say just, it could be a punch, like it just be, you know, and so it's really holding your core strong, and just kind of channeling all that energy into that movement.
And I'm wondering, Joe, if you could make it so that you're really focusing on, because you're breathing out, and what we know about the exhale is that will help you with regulating your nervous system, getting from sympathetic. It's sort of like a vagal break. So as you go, if you could go a little bit slower.
Yeah. I think that's interesting. It makes me feel like that stronger, so that like the distress will seem very small to me. I can sit there for the 20 seconds. Yeah, you know, I might give that a try. And when my kids start seeing me do this, I'm like, oh no, here it comes. I'm going to lose my phone. So,
yeah. So you said it makes me think that I'm stronger. I also want you to feel it more. So when we're talking about the bodily interventions, I'd like for you to actually really be in the state of embodiment of not thinking about what it's doing for you, but actually really feeling what it's doing for you, really exhaling completely. And just notice if you did that, for a few minutes before you walked in, how it may change your experience. And if it doesn't, if it makes things worse or it doesn't do anything, then we'll try something else next week. But this would be the intervention I would, yeah.
I'll give that a try. I mean, I never would have tried it, and it's only one off. Might as well. I mean, it's certainly is going to be repeating the same thing I've been doing for the last 10 years. So
yeah. And that's one of the things that I was wanting when we were talking about doing a body-based intervention. I was thinking, I could do soothing rhythm breathing, or I could show them some kind of yoga move. But the thing is that you really have to individualize it based on what you know about your client. It's sort of like metaphors. You don't want to use a metaphor about baseball for a ballerina, right? So you use you sort of tailor the processes based on the individual.
Yeah, and that's really nice, very great example, Diana, a demonstration of how you customized it and individualized it for me. And there was a playfulness to it, like it didn't have to be the right thing. You didn't have to have the answer. So that's the variation part. You don't have to have the answer. The process is, let's try it and then see what happens.
Yeah. So Joe, there was a question, I think it's a great question, is like, it seems like what we're doing in the chat, until now, this is from Thomas Polanski, until now, network diagramming is mostly subjective, or is there a statistical model for mapping these things? Joe, this is what you've been working on. Yes. What data would you need to collect and how, so that the nodes, their relationship, which node probably needs the most attention, could be generated automatically, or is that not possible?
That's a great question. So this is an example of perceived network, but there's other kinds of networks. Like you could have the therapist generate a network, but the network you're describing, I would call it a empirical network or an evidence-based network. And we're working on an app called MindGrapher, which will record people's in their daily life for a period of time, and then actually look at, what is actually driving well-being for the person. So for some people, we've looked at this for a lot of clients already, it's a lot about health. Like when they do something unhealthy in the day, that is associated with sadness and anxiety. But for others, it isn't like that. Health isn't the big driver. It may be something else. It may be lack of persistence at something, or it may be that they're hurting their connections with others. So what we've noticed is that there's a huge amount of variation of what processes might be driving the same, say, anxiety state. For some, it could be health behavior. For others, it's social. For others, it's much more behavioral, like they're just not able to stay with their commitments. For others, they feel like they can't express their emotions. So it's, and that's identified empirically.
Yeah. So that is around the corner. And what we're demonstrating today is more of a subjective example of how you create a network subjectively with the client. And we'll talk about some other ways that you can create it at the end of this. But so we've talked about psychological processes. We talked about physical processes. We don't have probably time, there's only 5 minutes left, Joe, to demonstrate the social processes, but there's so many different social processes that can play a role in your client's problems. And these are some examples. I also want to say these are not necessarily exhaustive. So we're trying to get out of the box, but then we're creating all these boxes. And these are some of the ones that, that you can't have everything on this sheet, but some of the ones that you may assess for. And the one that really seems to be showing up in Joe's network, it's really, we're putting it under difficulty managing others, which has to do with basically being an effective parent, which is sometimes, being a leader, being able to set limits with people, set loving limits, have that secure attachment exist while you also are saying no about something. And that would be the process that maybe we would try out with Joe. You and I could do something. We had talked, maybe we'll demonstrate this in the 6 hour.
We're like a role play, experiential role play where I practice different parenting things. So it's actually the social level.
Anything else you want to say at the social level, Joe, around these processes?
I think that covers it pretty well.
And then we also have this whole environment that Joe and his son and all of us of parenting teens is in, which has to do with, gosh, you're in the world of technology and teenagers with phones. This is the first time we've ever experienced teenagers having access to technology. And how is that set up in your home? And how does that influence the degree to which this environment, to the degree to which your son is using technology, the degree to which you're using technology? And so environmental elements can play a lot of roles. This one that I would probably target is just the influence of the environment on your son, like maybe collaboratively creating some boundaries around his phone use. Like, is it a way in our house, we have a drawer that every device goes into, and we shut it at a certain time of the day. Yeah.
And that's really nice, because it shows you how comprehensive this is, how the network would consider all these different levels and dimensions. And I know I have my favorite things, and there's things that I rarely look at, but we hope that this kind of approach would help you to kind of see the whole map.
Yeah. So these environmental elements, I would say, oh gosh, are often ones that get neglected in psychology. We kind of don't think about things like how a toxic work environment or time poverty or unfairness, discrimination, oppression are playing a role in our clients' lives. And I think social psychologists and social workers tend to think more in this realm, but these are all things that you also want to be assessing for and addressing in therapy and supporting your clients and how to best navigate their environment. So this is the big master sheet, which is something that Joe and I came up with. But this is the original model, which is the extended evolutionary meta model, which includes these dimensions of self and these levels of biophysiological and social cultural, and the variation, selection, retention, and context that Joe was talking about. What do you want to say about that, Joe?
I think that's fine. I think we can kind of, if we go back to the previous one, which I think is much prettier, I think that's maybe even the previous one where we're not even high, like it's just, so you guys have access to this, and yeah, hopefully start to see the kind of scope that I think will be the new therapist. We'll be using analytics. We talked a little bit about that, with the causal networks being derived from people observing their lives during the day. You'll have to be a little bit of a dietitian, a psychologist, a social worker, a psychodynamic therapist. I think it won't be eclecticism in the sense that you will still have your core theory and model that you work from. But I think it would be really helpful if we could allow ourselves to also help people in every aspect of their life, and not just say, oh, well, I'm only a specialist in affect and psychological processes. If we could, because all these things are connected in a single network, and everything is influencing everything. So we need to consider the whole human picture, from their body to their psychology to their social world.
And in the 6-hour training that Joe and I will be doing, we'll be talking about how to determine the importance, so subjective importance, data-driven importance, network-derived importance of what you're targeting in the network. Sorry, we're going to move through these. We'll be going through some of those slides that you missed. But we'll also be talking about how, the questions that you would ask, and you would get a chance to go through a network modeling in a role play, and walk you through each of these. And Joe has a great handout that really breaks it down into a step-by-step approach.
Yeah. So I guess we don't have time for questions. We're right at the end, Diana.
Yeah, there was one question that was probably a good last question, which is, what is the most important thing to remember when taking a process-based approach with clients? It's a good ender.
Yeah, I think that's a good question. It could be a lot of things. It could be personalization, considering the whole person, from body to psychology to social world. Which of those is most important? Gosh, I would say don't assume that your favorite intervention is inherently always going to work, I guess would be one thing I take away. I love compassion-focused interventions, but that's not always the first thing I should be focusing on. I love willingness type interventions, like what Diana did, but sometimes people are in a different place. They just need some help with goal setting, or maybe they need a deeper dive into their psychology with their parent. So yeah, I guess, do you have one, Diana? Those are three that I would think
Yeah,
of.
I would just say that individuals are complex, and to not try and fit them into some kind of box. And that's what PBT offers you a chance to do, is to look at the complexity of the person in front of you. And it brings and evokes a curiosity of like, I just want to understand and learn more about all of these different things that are playing a role in your problem and in your life, so that we can actually help you get more wiggle room with the things that you're struggling with. So assume some complexity, but you know that's sort of a beautiful thing. And you have a chance to kind of map it out and get curious with your clients. Yeah. I also just want to mention that for those of you that sign up for the 6-hour course, you get 50% off for that 6-hour course. So it's usually $249, but if you sign up because you attended this, it's $125, and that's a 5 CE course that's going to be happening in December. You can sign up now. It's located on your PESI website that you use to get into this. And that Joe's joining me in a Wise Effort Together summit that I hope that you all will attend. It's also free. And he's talking about emptiness. And that's a really fun summit. I have Jack Cornfield on, Stephen Porges, Trudy Goodman, Joe, Marcela Matos from Compassion Focused Approaches. And he's also been on your Life and Process podcast. And for those that want to just be part of this bigger community of process-based therapy, go to contextualscience.org. There's a lot of resources for you there. And there's a lot of resources that are going to be coming out that you'll want to know about for process-based therapy, like things like MindGrapher. Yeah.